iGlaucoma presents a video series.
I'd like to share with you two cases of MIGS being performed after a failed trabeculectomy. The first is of a GAT procedure being performed on a young 30-year-old African-American male with juvenile open-angle glaucoma who had failed a prior trabeculectomy. The lighted microcatheter has already been placed in the anterior chamber through a paracentesis. We'll use a Cook dual blade through a temporal clear cornea incision to remove a strip of trabecular meshwork from the nasal angle. This patient was referred to me with a dense ring scotoma in the right eye in excess of minus 30 decibels mean deviation on Humphrey visual fields and uncontrolled on 5 drug classes. We are now threading the microcatheter into Schlemm's canal with intraocular forceps. Traditional trabeculectomy with mitomycin C using a fornix-based conjunctival flap was the first intervention we pursued for this patient because of the severity of his field loss and the desire to get his IOP into the low teens. Unfortunately, he developed a very ischemic conjunctiva near the limbus and subsequent blebitis with a persistent bleb leak. The blebitis was successfully treated with an ischemic bleb excision, and conjunctival advancement was performed, augmented with the placement of Olagen collagen matrix. Eventually, aggressive episcleral fibrosis set in, and the bleb failed despite 2 bleb needlings, with IOP settling in the high 30s on Rocklatan, Combigan, and oral Diamox. And so here we are seeing if GAT will work where the trab had failed. Now that the catheter has finally made it all the way around the canal, we'll complete the trabeculotomy. I'll create a new paracentesis and use it to gently tuck the prolapsed iris back inside the anterior chamber with an intraocular cannula. We'll then remove the viscoelastic with bimanual IA. Postoperatively, this patient did well, with his IOP settling in the 12 to 14 range on Rocklatan and Timolol with over a year of follow-up. Devinder Grover in his series found that GAT had a relatively high failure rate in those with severe field loss and those who had failed prior trabeculectomy. I think in this case, the circumstances may be different in that this patient is actually quite young and his distal outflow system may be more intact, allowing this procedure to be successful. By contrast, older patients who have been on years of topical treatments with distal outflow system atrophy, GAT may not work as well. After irrigation and aspiration to remove the viscoelastic, we will seal the wounds with hydration. The second case is of a 63-year-old Caucasian female with primary open-angle glaucoma who suffered a devastating suprachoroidal hemorrhage after a trabeculectomy in her left eye, leaving her 2400. We are now operating on her right eye, which is still 20/20, but does have minus 15 decibels of mean deviation visual field loss and has demonstrated slow progression over the years despite multiple trabeculectomies and blood needlings, phaco eye stent, and micropulse laser. I start by explanting her eye stent and following that up with ab interno canaloplasty performed with an Omni system. We are going left-handed here in an effort to dilate the nasal and inferior half of Schlemm's canal in this eye, assuming that most of the collector channels and aqueous veins are there. Because of the choroidal hemorrhage in her left eye, this patient has been understandably reluctant to have any further incisional surgery on her right eye, but with an IOP of 26 despite 5 topical drug classes with slow progression on fields, she understood the need to try to do something. We are now implanting the first hydrus left-handed into the nasal canal of Schlemm, pre-dilated by the Omni system. We discussed many surgical options for this patient. One was glaucoma drainage implants, but her left eye now has corneal edema after an Ahmed glaucoma valve, and we were concerned about this occurring in her right eye. I have now moved to sit superiorly and am creating a third supranasal paracentesis. I've angled the microscope about 50 degrees and I'm asking the patient to tuck her chin and look slightly downward. This will give good visibility to the inferior angle for implantation of the second hydrus. We also considered ECP, but she suffered some mild cystoid macular edema after her micropulse treatment and wished to avoid this. We decided against the GAT procedure because of the risk of post-op hyphema, limiting the rapidity of her visual recovery in her only seeing eye. So we finally settled on this canaloplasty and hydrus. Indirect gonioscopy shows excellent position of the 2 hydrus implants, and we'll finish with IA. This patient did well postoperatively with IOP consistently 11 to 13 across 6 post-op visits out to 1 year. However, the patient is still on all her topical glaucoma drop therapy. So a good qualified success for this monocular patient status post multiple failed trabeculectomies with a surgery that allowed for rapid visual recovery with minimal risk for complications. Thank you for watching.
Want to help with improving your glaucoma patient's adherence? Want to know the best kept secret behind better doctor-patient relationships and more patient trust? The answer lies in improving glaucoma patient education, an unmet need. I'd like to introduce you to the Glaucoma Guidebook, expert advice on maintaining healthy vision, vetted and published by Johns Hopkins University Press. This book is a pathway to empowerment for the glaucoma patient through enlightenment, understanding, encouragement, and direct advice to become a self-advocate for blindness prevention. This, for the provider, decreases chair time and explanations and enhances the doctor-patient relationship through care, increased trust, and ultimately, the patient getting on board with treatment plans for better outcomes. The Glaucoma Guidebook. Get your copy today, then share.